Good evening, everyone, and welcome to the Maddie Riewoldt's Vision 2025 series of patient and family educational sessions on bone marrow failure syndromes. So my name is Amy Coote and I'm the CEO at Maddie's Vision. Before we start, I would like to acknowledge the traditional custodians of the lands on which we're meeting across Australia. So for me, that's the Wurundjeri people of the Kulin Nation. I pay my respects to elders past and present, and would also like to extend that respect to any other Aboriginal or Torres Strait Islanders joining us here tonight. So as many of you may know, Maddie's Vision is the only organisation in Australia dedicated to driving bone marrow failure syndrome research, education, advocacy and support for patients and families. Over the last decade, we've funded almost $10 million across 36 cutting-edge research projects, including 2 clinical trials which have seen more than 400 patients participate. We now have relationships with 24 leading medical research institutes, hospitals and universities across Australia and even globally. We are the source of support for patients and families with bone marrow failure syndromes in Australia and have our dedicated tele support service and peer support program. We also provide these fabulous educational sessions, which thanks to you are co-designed to meet the needs and hopefully answer the questions that you have. So we've now supported over 160 patients and families across Australia. And if any of you joining us here tonight haven't had the opportunity to participate in those services, please do reach out to us because we are here for you when you need us. So the evening's program will focus on navigating the journey of bone marrow transplantation. So our guest speakers will share insights on preparing for transplant, managing challenges during transplantation, post-transplant care strategies, and long-term follow-up for patients and their families. So following the presentation, we'll have a 30-minute Q&A session. So thank you so much to everyone who submitted questions prior. These have gone to our fabulous speakers and they've really endeavoured to cover topics in their presentation tonight. But if there's opportunities later to expand on those, or if you have further questions, then you'll be able to do that during the Q&A session. So I'm now delighted to introduce our first speaker, Maddie Gilsenan. Maddie is the bone marrow transplant and cellular therapies nurse practitioner at the Children's Cancer Centre at the Royal Children's Hospital. Welcome, Maddie, and over to you.
Thank you so much. I always love being a part of these sessions, so thank you for having me. Just checking that you can see my slides okay?
That's great, Maddie. Thank you so much.
So I am going to talk a little bit today about the preparation for bone marrow transplant. And I obviously work at the Royal Children's, so I'm very used to paediatric specific references, but I think a lot of the things I'll talk about are very translatable across the paediatric and adult setting. So will be relevant if you have a child undergoing transplant or maybe a family member. So something that I always just like to mention, and something that I always have a little bit of a discussion about with the new staff members that are starting in our department, is that what can sometimes cause a little bit of confusion with families is that there's a few terms that are used interchangeably when referring to a bone marrow transplant. So you might hear referred to as bone marrow transplant or stem cell transplant or hematopoietic stem cell transplant, and they're all sort of referring to the same thing, so that can cause a little bit of confusion when you might be reading online. But basically the bone marrow transplant process is when blood cells that are donated by another individual are infused to the patient. And so by doing this process, we're replacing bone marrow with healthy donor cells. And we perform bone marrow transplants for a number of underlying conditions. And a big portion of those, particularly in the paediatric setting, is bone marrow failure syndromes. So I think a lot of people, when they think about bone marrow transplants, think it's for a diagnosis of leukemia. But definitely we do a lot of bone marrow transplants for bone marrow failure syndromes, whether they're inherited conditions or acquired bone marrow failure syndromes. We know that the bone marrow transplant process is quite a complex therapy and it requires a really extensive workup period. And I would say particularly in the bone marrow failure setting, there is a lot of workup that goes into referring for a bone marrow transplant. And Alex will talk a little bit in the next presentation about sort of the inpatient admission, but during the transplant process, patients are admitted to the ward, which is usually around a 5-week admission, particularly in the paediatric setting. And that allows for the administration of some chemotherapy to prepare the bone marrow, and then the donor cells are infused. Just sort of like a blood transfusion. A lot of patients think that they have to go to theatre for the procedure, but it's just administered through a central line. And for patients we treat at RCH, and obviously at Peter MacCallum and the Royal Melbourne, treat a lot of patients from interstate centres. So we require our patients and families to locate close to a transplant centre for usually around a 3-month period. One of the biggest things that goes into the preparation for bone marrow transplant is actually finding a donor. And we know that this in some patients can be very easy and quick, and in other patients can take a little bit of more time to sort of find a suitable donor. And so we know that the blood stem cells can come from either the bone marrow through a bone marrow donation from the donor, which they have under anaesthetic, through peripheral blood, which is sort of like an apheresis procedure, similar to if you're sort of donating blood. And then more so in the paediatric population, we do use a lot of cord blood, and that can either be from a matched sibling cord or potentially an unrelated cord that has been donated to the cord blood bank, which we have here at RCH. We know that there's around 25% chance of a sibling being a match. So when we know that a patient is an indication for a bone marrow transplant, one of the first things we do is test the siblings to see if they're a match. If we have no sibling matches, we have a look on our big international unrelated donor pool, which includes patients from all around the world, and we have particular donor centres that we get a lot of our donors from internationally. And then recently, this is probably a lot more initially in the adult setting, but in the paediatric setting, recently also we've started to do a lot more what we call haploidentical donors, whether that be from a parent or a close relative. And so one of the most important ways that we find the donor is we need to do some testing called HLA typing, or you might have heard it referred to as tissue typing. And that is the best way to determine the best match for our patient. And so HLA stands for human leukocyte antigens, and these are proteins that are found on the cell surfaces all throughout the body. And we want to find the closest match to the recipient, because we know that that results in sort of the best transplant outcomes is finding the best matched donor that we can find. And so these blood tests this testing, the HLA testing, can either be done by a blood test, or in some of our younger paediatric siblings, we do a buccal swab, which is a swab of their mouth. And we know that these tests can take up to around 2 weeks to find out. And we have a particular donor coordinators throughout the centres that their primary responsibility is to be involved in this process to find a suitable donor. Just a very brief overview of the bone marrow transplant timeline. So there's many different phases which will be spoken about tonight. But first is the diagnosis and workup phase, which is usually anywhere from around 2 to 3 months minimum, and sometimes much longer. And then, which I'll talk about in the next slide, is we do some pre-bone marrow transplant testing to look at all of the patient's organ function. And that's when the patient would usually relocate to close to a transplant centre. And then they have their inpatient admission and the very close follow-up in the acute post-transplant period, which Alex will talk more about. And then the long-term follow-up, which Yvonne will speak a little bit about. So before any patient is admitted for a bone marrow transplant, we do a number of what we call workup investigations to have a really good overview of the patient's clinical status before they come to us. And it's also really helpful to do all of these baseline assessments so that if any issues arise during the transplant process, for example, a particular infection, then we've got some investigations to refer to from initial, so we can compare if there'd been any changes, and that really helps our management. So some of the things, they're obviously very different for the particular types of transplants, but most commonly, patients potentially may have another bone marrow aspirate and biopsy before their bone marrow transplant admission. We do testing of the heart and the lungs, usually have a dental review to ensure there's no infection, have a close look at the kidneys, a hearing test, look at the eyes, and then we do, close to the transplant admission, some infection screening bloods, which happen on both the donor and the recipient. And I just wanted to mention, with one of the Nursing and Allied Health Maddie Riewoldt scholarships, we were very lucky to have one of our neuropsychologists, Alice, who her project was involving all the patients with bone marrow failure syndromes who went to bone marrow transplant, had neuropsych testing before their transplant and then after, which is amazing and has been really helpful in re-engaging patients back into school and society after their transplant, to provide really helpful strategies and monitor changes that potentially occur with the transplant process. And one of the other big things that is normally done in the lead up is patients will have a central line inserted. So it's really difficult in the transplant process with, I guess, the volume of medications for patients, particularly pediatrics, to have cannulas to deliver those therapies. And so all of our patients will have some form of central line inserted, which is most commonly a Hickman line, just to ensure that we're not having to be putting cannulas in all the time, and to allow us to deliver the appropriate treatment. In the pediatric world, I imagine in adults, doing all of these pre-transplant testing is a lot quicker. But in the pediatric world, we spend a lot of time preparing patients for all of these testings that will happen in the lead up. And so we spend a lot of time working through videos and these simulations that we have on our children's website, which are easily accessible, just to talk through what each procedure will be like, and even to work out if some of our children may require a general anaesthetic to have their workup investigations. So these testing can sort of span over a month or so period, particularly for our pediatric patients. For those patients who potentially are transfusion dependent in the lead up, so maybe a lot of our patients who have conditions like severe aplastic anemia, who are requiring blood and platelet transfusion support, that's something that we need to obviously monitor closely in the pre-transplant period. So we wanted to provide transfusion support to keep our patients as safe as possible. But in the back of our mind, we always need to consider that we want to minimize the iron burden, which you can sometimes increase by blood transfusions. So we want to sort of just give as many as necessary to sort of reduce some of those risks of complications in the transplant process, and also to reduce the risk of developing antibodies potentially to the donor. So that's something that we put a lot of thought into the pre-transplant period. Supportive care, that's a really big focus in the pre-transplant setting. So we really want to try and make our patients as, I guess, in best condition as they possibly can be for the transplant. And so that includes things such as some of our patients might have something called chelation therapy, which are medications to reduce a patient's iron burden if they have had a lot of blood transfusions in the lead up to their transplant. A lot of focus on infection prevention, which I'll talk about on the next slide. And we really use this time to have a lot of multidisciplinary involvement to really, I guess, make sure that we're supporting the patients and families as best we can throughout the transplant process. And that involves, I guess, pre-transplant psychosocial assessments, involvement from the dietitians to make sure we're maintaining, I guess, good nutritional status before the transplant, the physios and exercise physiologists. And in some of my research for what's happening in the adult space, I saw that at Peter Mac and the Royal Melbourne, they have a prehab clinic, which is amazing, which all of the patients will get referred to sort of focus on a lot of the psychosocial care and a lot of the allied health supports in the pre-transplant period. We really want to be really cautious about infection, particularly in the transplant, in the sort of couple of weeks leading up to transplant. We know that infections can sometimes delay the transplant process, unfortunately. So we need to be really cautious about infection in the lead up. A lot of patients will be on prophylactic medications to reduce the risk of infection, so really important to adhere to those prescribed medications in the lead up. And we really try and I guess, minimize infection by isolating patients, particularly in the few weeks beforehand. And it's probably much easier in the adult setting, but in the pediatric setting, we really try and sort of minimize infection as best we can, and particularly in our sibling bone marrow donors as well. So usually in the 1 or 2 weeks before transplant, we would potentially recommend the sibling donors not be attending school or daycare just in that lead up. But also it's tricky because we want to sort of maintain a normal home life as possible, but that's just something that's really important in the lead up to transplant. And really important to alert your healthcare team if a family member or the patient child is showing any signs of infection in the lead up to transplant. And then I just wanted to briefly touch on fertility preservation. It's a question we get a lot in the pediatric setting. And I just wanted to highlight that having a discussion with the treating team is really important in the pre-transplant period. We know that different conditioning regimes and different transplant processes can have different risks to fertility. Some potentially have a very low risk and some can have a high risk to fertility. So I think it's really important to gather that information in the lead up to transplant. And a lot of centres will have a oncofertility nurse consultant that potentially will be responsible for these conversations. And even if fertility preservation options aren't taken up, I think it's really important just to have that information for future reference. In the pediatric setting, we do have some fertility preservation options available in both the pre and post-pubertal setting. In the pre-pubertal setting, a lot of the time these are sort of experimental treatments, and yeah, just important to have a discussion with the treating team to see if this is potentially an option that is feasible and something that you would like to consider. And just finally, psychosocial care. I've already covered this, but really important to explore what supports might be available during the pre-BMT and the BMT period. Really important to engage with social work if available, to talk through things like Centrelink applications for carer payment or concession cards to help with medications, what local accommodations or supports are available if you're from regional or remote areas. And then also, obviously, there's a lot of amazing charity supports out there that can help with, I guess, financial, practical, and psychosocial support that may not have been available to patients and families before in the pre-transplant period. And then obviously I just wanted to talk about mailing. It's obviously in the Maddie Riewoldt telehealth service. It's a service that is very highly recommended by a lot of our patients and families. So definitely just wanted to add that in there, something worth looking into. And just my final slide, normally in the week or two before the bone marrow transplant admission, patients and families or carers will have a consultation with their primary care team. And this will be to discuss the individual transplant treatment plan, including the conditioning agents that are given in preparation for the transplant, and also to go through all of those investigations that were done in the pre-transplant period to have a good idea of the patient's health status before the transplant period. And in the pediatric setting, we really try and bring pediatric patients into these conversations and have sort of age-appropriate conversations as best we can, so they have an understanding of potentially what's going to happen, but obviously very age-appropriate. And we really try to engage a lot of our adolescents in these discussions as well, whether they just stay for the first part of the discussion and then they leave and parents and carers can stay for the rest. But really important to involve patients. Even our young patients usually like to have a good understanding of what they might expect. And I think we'll take questions at the end, so I'll just stop sharing my screen and then Alex will present the next part of the presentation.
Thanks so much, Maddie. Really appreciate that level of detail, and of course the shout outs to our Fiona Riewoldt fellow Alice and also our tele support nurse. I will just mention that and for those that don't know, we also have Rachel Edwards, who is our new tele support nurse joining mailing on the team, has been with us for a few months now. So both between mailing and Rachel, it is available between Monday and Thursday every week. I now have the pleasure of introducing Alex Riewoldt. So Alex is a post-allogeneic bone marrow transplant nurse practitioner at the Peter MacCallum Cancer Centre and the Royal Melbourne Hospital, and Alex will be presenting on care during the bone marrow transplant process. Over to you. Thanks so much, Alex.
Thank you, Amy. Thank you for sharing my slides, Jaya. Thank you for having me present tonight. I'm exceptionally grateful that we've got Maddie on the line because I have a very strong adult focus, and if there are any gaps, I know that she'll be able to fill us in. So next slide, I'd like to explain a few terms just so we start on the same page. The donor, and I don't know why I'm going basic, the donor is the person who provides the stem cells. The recipient is the patient, and stem cells are the most basic type of cell from which all blood is produced, and bone marrow is the organ responsible for that production. I think this can be a bit of a daunting discussion, so it helps to clarify some of the language. Next slide. So then we ask, what does a successful transplant require? And it's three things: a disease with evidence that transplant improves their outcomes, a patient who can tolerate chemotherapy and its complications, and a suitable donor. And Maddie has made it very clear what a suitable donor looks like. At its core, allogeneic transplantation involves infusing these donor stem cells into the patient, and we do this, as we've said, to treat diseases like leukemia, lymphoma, aplastic anemia, or other bone marrow failure syndromes. And for it to be successful, the donor cells need space to grow. The patient's immune system must be suppressed so that it doesn't reject the new tissue. And to prepare this, the patients receive conditioning chemotherapy. And this serves several purposes. It removes the patient's own bone marrow and creates space, suppresses their immune system, and helps, if applicable, reduce the amount of cancer in the body. But it also wipes out any normal stem cells. So we need the new stem cells to come in and replicate, making the new red cells, white blood cells, the immune system, the platelets, and so on. So what does a successful transplant look like? And it means the disease that we've transplanted for is in remission or is resolved. The patient no longer requires red cells and platelets to be transfused. Their new immune system is working and able to fight off infections on its own. And this can take a little while. And there are a few steps involved that we can get into. And there's no significant enough graft versus host disease that could impact your quality of life or make you sick enough to be into hospital. And we'll go into that a little bit further. Next slide. Sorry, go back actually. Many transplants, many patients who have, sorry, do you mind going? But yeah. Many patients who referred for transplant have already had chemotherapy in the past. And so they kind of know what to expect from a hospital stay. And typically, you should expect the transplant admission to last anywhere from 3 to 4 weeks if all goes well. The patients come in, as you can see there. They receive their chemotherapy. They get the donor cells, and we call that our day 0. They remain in hospital until their blood counts recover. And during that time, they're monitored very closely for side effects, such as nausea, diarrhea, infections, and fevers. They might need medicines through the drip, be that food or all of their medicines as well. And nurses and doctors work constantly to manage these complications. But it is one of the most intense treatments that people can go through. There are a lot of protocols and steps in place to ensure that people are kept safe, but it means, things like waking people up in the middle of the night to check their temperature or their blood pressure. It means having scans at inconvenient times, and it can be a really tricky time. Day 0 is, the day the donor cells are given, and this is a beautiful day. We often describe it as a new birthday. And in reality, as Maddie said, it's not a surgery. It's an infusion. Quite simple, slightly less than a blood transfusion. And the cells find their way into the bone marrow on themselves, all by themselves. There's no surgery involved, but it's very symbolic. And remember that transplant is never a one-size-fits-all process. Each patient's journey is shaped by the disease that they've had, the treatments that they've had coming into it, personal circumstances, and preparation, both physical and psychological, is key. And we try to be, as healthcare professionals, as honest as possible, but it is really tough. But this is the chance for cure for so many blood disorders or blood cancers. So when you're going through this, ask questions, eat what you can, stay mentally engaged, see your loved ones, and remember that, the nurses, the staff, we've seen it all before. Ask as many questions as you need. But I'm going to delve a little bit into some side effects now. Next slide, please. So mucositis is one of the most common side effects, and you might have had it before, from chemotherapy or radiation. It causes the mouth and sometimes the throat and further down to become sore, red, or develop ulcers, and it can make eating and drinking really uncomfortable. How do we manage it? We manage it with good oral hygiene, special mouth rinses, pain management, pain tablets, pain through the jip, and sometimes we give you medications to help your mouth heal faster. Staying hydrated and avoiding eating foods that can irritate the mouth can be really helpful. But remember that this will pass and it will get better as your immune system recovers. Next slide. Twofold, I bring up this slide. One is to talk about sepsis, and the other is to talk about the risk of graft versus host disease, which is considered the bogeyman of transplantation. So sepsis is probably something you've heard of before. It's when the body gets an infection and it spreads through very quickly and causes whole body inflammation. And that's why we watch for fever, feeling unwell, rapid heart rate, or confusion. And the reason we keep you in hospital to recover is so that we can act fast. One of the reasons you're most vulnerable to sepsis or infection is because of the medicine we give you to prevent graft versus host disease. So graft versus host disease is unique to allogeneic stem cell or bone marrow transplantation. And it happens when the donor's immune systems recognizes the patient's body as foreign and begin to attack it. And this often manifests in things, rashes on the skin, diarrhea, or liver inflammation. It can be mild, or it could be quite severe, requiring people to be hospitalized or causing damage to their organs. There's always the tension between, if there is a malignant disease like a leukemia, that a small degree of graft versus host disease could be beneficial. But it's uncontrolled graft versus host disease is very dangerous. So preventing and managing it is central to the whole transplant process. And so to do this, we give you powerful immunosuppressing medications, sometimes for months on end, to reduce this risk while balancing the donor immune system to function. Next slide. Yes, this is a good way to prevent, what are the ways that we can prevent infections and sepsis? Obviously, frequent temperature monitoring, hand washing. Know that we will look preemptively for bacterial, fungal, and viral infections and give you medicine preemptively to prevent that. Social isolation, I think Maddie said this perfectly, but social isolation is very helpful. But we like you to stay also 30 minutes from the hospital. Next slide. Our carers are our most important players in this game. They play an essential role. It takes a village, be it a child or be it an adult. It is extremely important that your carer is with you, or you are the carer and you are with your loved one this whole time through, from the first consultation and beyond. There's so much information to absorb. You're vital in supporting the patients through hospitalization, and then importantly later, in recognizing these signs of infection that we've spoken about or graft versus host disease. Next slide. After a bone marrow transplant, these are the things that carers need to look for. After a bone marrow transplant, it can honestly feel like you're taking half of the pharmacy every day. And there are tablets for preventing infections, there's tablets to stop your body rejecting the transplant, tablets to stop your stomach coping, and a few more to deal with. And it can be very tiring to keep track of them all. And, most people find things like pill organizers or phone alarms really helpful. So over time, it does get easier. We will pull the medications off, but time frame wise, you're looking at around 3 to 6 months with it weaning off. It's all about protecting the new bone marrow, preventing graft versus host disease, and keeping you safe from infections while the immune system rebuilds. Next slide. This, I think, is a really good example of how it is a balancing act while you're in this peri-transplant period. As I said, with all these tablets, we're avoiding the risk of graft versus host disease, supporting through nausea, and the taste changes can be really quite harrowing post bone marrow transplant. Everything might taste too sweet, too salty, too off. Favorite foods might seem strange. It's very temporary. That's the good news. Trying different things using plastic cutlery, focusing on different textures, preparing the palate with acidic or ginger supplements can help with these sorts of things. But overwhelmingly, we use a lot of medication. And it's one of the most common things that people say to me is, this is the most tablets I've ever taken in my life. And they're not wrong, but we're balancing and monitoring all of these risks. Next slide. I think here I want to go back to talk about how after a bone marrow transplant, your body is working, or your loved one's body is working overtime to heal. And so you need things like extra energy and protein, and you want to try and get a high protein, high calorie diet. People stress to me a lot about eating perfectly. And it's impossible at this time point. Gaining weight is impossible at this time point. Do what you can to keep the weight stable, and that is perfection. Nausea is a very common side effect. You always want to try and get on top of it early. Prevention is much more effective than cure, so we often will give you things before you feel nauseous in the first place. And yeah, people will often ask, I think the medicine is making me sick, and they're not wrong, but the purpose is to prevent the graft versus host disease. It is a really significant balancing act. It's a slow process, but you have a lot of support around you. This is why we want to have a carer involved. One of the things that's very common is to feel a bit foggy or mentally flat post bone marrow transplant. And that's a combination of medication, hospital visits, fatigue from, you're essentially having both a bone marrow and a new immune system transplanted in front of you. And, what would you say to someone who had a heart and a lung transplant? You would say, take it easy. It's not a sign of weakness. It's very common for people to lose focus. And the mental side of transplant can be tricky, but keeping the close ones around you, keeping some sense of routine, and keeping a vision of the longer goal that's in mind is really important. Talking about it can help. Next slide. Talking about it can really help. That could be a medical team, that could be a psychologist. Be gentle with yourself. Recovery post bone marrow transplant is a marathon, but it'll be finished before you know it. And then we get to day 100 and beyond. So there's routine assessments along the way. We do, depending on the various illness, be it leukemia, lymphoma, or aplastic anemia, or others, we'll do bone marrow biopsies, PET scans, a lot of blood tests, and we see how these are going, and we'll change your medication in response to that. And they could add additional therapies. We could take away medicines. Some of these are routine, like monitoring for viruses, and some are tailored specifically to the transplant. Day 100 is a concept rather than a date. And it kind of feeds back to what I was saying earlier about a successful transplant. For some people, they meet these goals earlier than day 100, and others might meet it later. Rarely is recover a linear process, but we will get there. Um, the next 100 days or so after the transplant, as we taper the medicines, can be challenging, but your new immune system will rebuild. And then we get to an exciting time point around 6 months or so where we restart vaccinations and things like that. And we recover you from your bone marrow transplant. Your energy levels, your body might not be quite the same. And that's when we hand you over, as you're learning your new normal, to Yvonne into late effects, which I'd like to hand over to you now.
Thanks so much, Alex. Really, really appreciate that. I think we may have been a bit ambitious trying to fit in all of this excellent content in the time frame that we've got. So absolutely bear with us if we do run out of time. No, not at all. If we do run out of time at the end, please know you can submit questions back to our team and we will absolutely follow up with Yvonne, Alex and Maddie. But now I have the pleasure of introducing Yvonne Panek-Hudson. Yvonne is a nurse practitioner in the clinical haematology service at Peter MacCallum Cancer Centre and the Royal Melbourne Hospital, clinical lead for the allogeneic bone marrow transplant long-term follow-up service and associate Director of Nursing for Haematology and Medical Oncology. So Yvonne is going to present the late effects or long-term follow-up following a bone marrow transplant. Thanks so much, Yvonne.
Thanks, Amy. Can you see my slides in the right format?
They look great. Thank you so much.
Thank you. So thanks to Amy, to Jaya, to Sherry and the Maddie Riewoldt Foundation for inviting Maddie, Alex and myself. So I'm going to be talking about the period of time from 2 years onwards. So what we call long-term follow-up care in the service that I work within. Some people call it survivorship care, which is also correct. And some people call it late effects care, which is also correct. So those terms are used interchangeably. Oh, my slides are not progressing. That is very strange. Oh, there we go. Thank you. We are an adult centre who are quickly developing experience in looking after adolescents and young adults transitioning from paediatric to adult care. But my presentation is focusing on adult long-term follow-up care because even when we referred young people, they have reached 18 years of age before we start seeing them. So survivorship care is very complex, but it's a wonderful space to work in because it is the period of time where we help to support people transitioning off active treatment. And that may be immunosuppression, they may be continuing on immunosuppression, or they may be on some maintenance therapy for certain diseases, or maybe off treatment altogether. But, our focus is on supporting rehabilitation, including things like return to work, return to study, supporting them alongside their primary physicians who are planning for disease-specific and treatment-related follow-up, and helping people receive the psychosocial and community-based support that they require. So the main goals of long-term follow-up is screening, identification and treatment of potential and late effects, education and counselling around what to look out for and what we're going to do for people. We have a real focus on self-monitoring and self-management because we want to support people to be able to return to doing the things that they want to do and be the best versions of themselves they want to be. And so we want to be we don't want to be the predominant feature in their lives. We want to be in the background supporting them. We want to support community screening adherence, psychosocial support, fertility assessment and counselling, vaccination adherence. We want to help people identify their goals for the long term and assisting them with navigating their way through those goals. We want to help people connect with their GPs, and we want to help them to have care in the best location for them and for their carers. And that may be having their long-term follow-up care through their GP. And also what we do in long-term follow-up is a lot of data collection, because what we want to do is ensure that the care that we're providing to people year on year in long-term follow-up is evidence-based, both from an international perspective, but also based on a local perspective. So looking at our own data and applying it to our guidelines. We have a significant number of people who come to us, and I'll talk a little bit about our service in a moment, but as you're probably aware, for people who are alive and disease-free at 2 years post-transplant, they have greater than an 80% chance of being alive at 10 years post-transplant. And so this is a wonderful space to work in. But what we do know is that people who alive and disease-free post-transplant are at variable risks of developing late effects. And this is dependent on their diagnosis, their prior treatment, the type of transplant they received, their personal, their family history, and their health behaviours. So patients come to long-term follow-up allogeneic bone marrow transplant follow-up clinics at 2 years post-transplant. People are referred to our centre from both adult and paediatric centres. There are a number of long-term follow-up clinics right across Australia, both in the adult and the paediatric sectors. And in addition, we also do a lot of shared care with GPs. So there are patients who are at low risk who we can actually support GPs to provide long-term follow-up care in locations more suitable for patients, particularly if people live in regional, rural or interstate. We also occasionally get referred people who have moved to Australia from overseas, and we also have patients who hear about our great service and self-refer to come and see us in our long-term follow-up clinic. So we're not just exclusively for people who are transplanted within our centre. We've seen and continue to see over 700 patients on an annual basis. We see people from the age of 18 to 75 plus. We have more men than women who come to our clinic, and patients vary in years post-transplant from 2 years, at which time they're eligible, to 40 years post-transplant. And I've got a 35-year history in allogeneic bone marrow transplants, and see people who I looked after as a graduate nurse, which is absolutely wonderful. You'll see here that and Maddie mentioned this before, actually, in her presentation, the mix of patient diagnoses. Given that we're an adult centre, the bulk of our patients were transplanted for leukemia, but as you can see, we also see people in long-term follow-up who were transplanted for lymphoma, an increasing number of people with bone marrow failure syndromes and other diseases as well. And obviously the patients with bone marrow failure syndromes are the predominantly, although not exclusively, but many of them are young adults who were transplanted as children who transitioned to adult long-term follow-up. So what are late effects? This can be quite a confronting picture because it's got everything on it, and it's really important to be mindful that this is just essentially an omelette of with everything in it, and spells out every possible late effect that people can develop. However, when people come to see us, we are very nuanced and bespoke, and we really consider patient-specific care. So we consider the things that I mentioned earlier, you know, what disease people were transplanted for, what type of treatment they received prior to transplant, because people don't come to transplant as a blank canvas predominantly. So we think about what chemotherapy they had previously. Did they have any radiotherapy? How old were they when they had their transplant? How old were they when they were diagnosed? What are their health behaviours? What are their what's their family history? What other comorbidities do they have? So we consider all of that when we are creating our recommendation list for screening. The sorts of things that we take into consideration is history of chronic graft versus host disease as well, and whether people are on ongoing immunosuppression. We look at things such as people's psychosocial health. We consider their psychosexual health as well. We look at their nutrition. We look at their physical activity. We look at whether it's relevant for them to be participating early in community screening programs like bowel screen and breast screen. If people have been exposed to radiation, we ensure that they undergo full skin examinations. We look at things like bone density, and we also, and Alex and Maddie mentioned this, the importance of neurocognition and neuropsychology, and obviously, if relevant, we refer people for neuropsychological assessment, and we also revisit fertility with people in long-term follow-up, and obviously for people who have not had the option of fertility preservation, depending on the intensity of the treatment they received previously, we may retest their fertility to see whether they have any residual fertility, and if not, refer them for discussion around alternate parenting options if that's something they would like to consider. So we coordinate, we do a lot of this in our clinic, but we also coordinate specialist follow-up for all of these services. As I mentioned, we are a big referral centre, so we receive a lot of referrals for young people transitioning from paediatric care, and currently young adolescents and young adults make up about 15% of the entire population of our long-term follow-up patients. We offer in-person and telehealth reviews depending on what patients prefer. So patients come to see us on an annual basis. In preparation for their review, they complete bloods and any investigations that are due. And again, these are very bespoke. You know, some people may need to have an echocardiogram every 2 years. Some may have an echocardiogram every 5. Some may require a bone density scan on an annual basis because they continue on prednisolone. Some patients may need one every 5 years. It's not one size fits all, and we try and reduce the hospital visits and the investigations as time goes on. We invite people to complete patient-reported outcome measures and patient-reported experience measures, and we have about a 60% response rate or a return rate on these. Our clinic and many long-term follow-up clinics nationally and internationally are nurse-led, often nurse practitioner and nurse consultant led with multidisciplinary input, and that is the model of our clinic. Our clinic reviews are 45 minutes in length, although our new young people transitioning to adult long-term follow-up get a 60-minute review. We use all of our patient-reported outcome measures in the clinical review. So we don't just ask people to fill these surveys in and store them in a drawer. We use them in our clinical review, and we ask people to complete a personal goals section, and we talk about that with patients, and we ask them, we consider how we can help them achieve their goals. Our review incorporates both a physical and a psychosocial review, and counselling and education. We then create a care plan, which you can see on your screen. This is the front page of our care plan. And this is a summary of our conversations with recommendations and a really clear list of what we will do, what we're asking the GP to do for long-term follow-up, and what we've asked the patient to do. And obviously we make appropriate referrals to specialists and allied health as required. So, look, in conclusion, I'm finishing off with the first with the first slide that I presented, just demonstrating again that survivorship care is complex, but it's very comprehensive. It incorporates both physical and psychosocial care. Our main goals, as I said, are to provide patients and carers with resources to self-monitor and manage, to provide education about reducing risk of developing late effects, supporting patients to find and engage with their GP so they can support them in a location closer to home. And we have resources for GPs to upskill them in feeling more confident in providing long-term follow-up care. And really importantly, we've made sure that we have provided patients and carers and GPs with our contact details. So if they have questions when they're providing long-term follow-up care closer to home, that they can contact us for advice and reassurance at any time over the 12 months between visits with us. Thank you for your time. This is my email if you have any questions. This is a little bit of a plug for the Straight and Marrow, which is Alex's, and Alex and I are the co-creators of this podcast, which is about everything about allogeneic bone marrow transplants. And another foundation that I know Maddie Riewoldt Foundation has a close relationship with, which is Arrow, the Bone Marrow Transplant Foundation. They have some great resources on their website. They also hold webinars, so check that out. Thank you.
Thank you so much, Yvonne. Okay, now I will hand over to Professor David Ritchie, who is the chair of our Scientific Advisory Committee and director of our Centre of Research Excellence in Bone Marrow Biology, to facilitate the Q&A. So please put your questions in the chat or raise your hand. Any questions are welcome. So over to the group to make the most of David and the team's expertise. Thank you.
All right. Thanks, Amy, and thanks to our three expert speakers, all magnificent hematology nurses in their own right. And of course, we've been super lucky to attract them specifically to the field of bone marrow transplantation. So if there are things that people who are online would like to ask, pop them in the chat and we'll see how we go. There have been some questions sent through ahead of time, which I have in front of me. And I wonder if I might ask one of those questions of Alex, just to get the ball rolling. So,
Please do.
Alex, can you hear me? Yes, great.
Yes.
So clearly you outlined some critically important milestones during the acute care period of allogeneic transplantation. And the one that we all look forward to the most is engraftment.
Yes.
Seeing those cells repopulate after a period of very low blood counts, low white cell count, and need for transfusion for platelets and red blood cells. And then we start to see their little heads pop up around
It
about
is an exciting time.
towards the end of that second or partway through the third week. And it's very exciting to see, because it means people are getting ready, start to have the ability to prepare to get home, or at least out of the hospital. So we have a question from somebody before the webinar started, before the session started, and person has reflected and saying, look, person's been through a transplant, they're doing really well, they're actually feeling well, but the platelets haven't quite returned back to normal. And I suppose the question for you, on behalf of that participant, is that something that you see during the recovery of transplant, and what does it mean?
That's such a good question, and one I get honestly every day. And I think about platelets in this context, that they can be the canary in the coal mine, and something might be happening in the bone marrow mischief, and the platelets might drop. And that could be for a variety of reasons. It could be, we could speculate all day, but it could be medication, it could be infection. It could be that the graft in and of itself is struggling a little bit, which can happen sometimes, and is not necessarily the fact that the bone marrow transplant hasn't worked, but that the platelets are very sensitive to these outcomes. It's very normal. We see it often. And, hold forth is my advice. Your team will know what to do when this happens. They will investigate the variety of reasons. Sometimes it can be about the medication causing the cells to burst. Sometimes it can be about not having enough ingredients to make cells. It can be a variety of reasons, but it is not that the transplant has failed, and you just need to really stay engaged with your treating team so that they can explore that with you and figure out what's going on. But being aware of that is really great, and watching your platelets over time. You shouldn't be fixated on a number, but watching that trend over time is a really good signal that you understand what's going on with your transplant.
Excellent. I might just add a little bit too, because as Alex says, it's a common question, even for people who are back to sort of a general clinic review arrangement and maybe seeing the doctor or nurse practitioner or CNC every 4, 6, 8, or even 12 weeks. My interpretation of, if everything else is good, if the person is well, no signs of infection, other blood counts are good, this is just a part of the bone marrow that just takes longer to recover. And often one of the things that makes it a little easier to understand is that platelets and the platelet making machinery are the most fragile flower in the garden. If you might have a lovely garden bed that's got a bunch of different flower types, and some will put up with wind and sun and semi-drought and frost and still keep going and still keep producing beautiful blooms. Well, platelets are the little tiny fragile African violets or pansies that it only takes a 2-degree drop in temperature for them to start to look a bit sad, get a bit withered around the edges, and not be as prominent and as beautiful as they should be. And that's platelets. And so just very subtle changes in inflammation, very subtle changes of medication, or even just time, is a factor in platelets regrowth. So essentially, I agree with Alex. If everything else is going well, hold on in there. Platelets usually creep back up. The other really important element about that is normal platelet levels versus safe platelet levels. And whether you're a creationist or a evolutionist, we've had built into us a lot of redundancy for our platelets, and so even quite a relatively low number of platelets, it's very safe. So platelet questions come up very frequently, and thanks to Alex for answering that. I've got great questions coming through on the chat, and no doubt the presenters will be able to see them as I'm reading them, but I might just put this next question to Yvonne. And so somebody is asking a question here about thinning of the bones, osteoporosis, loss of bone mineral density. It's called a few different things. And it is something, of course, that we screen for and identify in patients undergoing transplantation. And the person is saying, why? Why is it increased? And what can we do about it?
Yeah, so thank you for your question. And as Dave said, we do screen for for low bone density, actually. So we screen bone density prior to transplant and at intervals post-transplant. And that's because we know that bone turnover is affected by a few things that our patients go through. I think someone did ask the question, is it steroids? So you get the golden ticket, because that is exactly right. So corticosteroids, prednisolone, dexamethasone, they affect bone mineral density. The other things that affect bone density are another thing that people experience when they have a transplant, which is reduced physical activity. So people lose weight, they lose muscle mass, they're not doing weight-bearing activity, and that also increases people's risk of developing low bone density. The other issue is people don't eat as well as they usually do, and can experience different levels of malnourishment, and that can also affect people's bone density. I will say that the type of low bone density we usually see is osteopenia, which is low bone density for age and sex, but not osteoporosis. A smaller number of people experience osteoporosis. Obviously, the other risk factor for low bone density is age. So we certainly look out for this at specific intervals post-transplant in all of our patients, but are mindful of it in our older patient population as well, which is a normal part of aging. Thanks for your question.
Super duper. And just as Yvonne's outlined, some of the things that your transplant team will advise is, of course, do exercise, eat well. You may need vitamin supplementation with vitamin D. And for some people, men and women, sometimes it's important to have sex hormone replacement in the form of either hormone replacement therapy, estrogen, or testosterone replacement for blokes. Those are also helpful for regaining bone mineral density. So there's a number of different ways of approaching that, but actively screening for it, as Yvonne leads in her clinic, is the key, because prevention is a lot better than cure. All right, we've gone over time, but I think we'll squeeze in a couple more questions because people have been so good to put their questions in. So this is a question from Maddie, and Maddie, so one of the things, as you quite rightly pointed out, in the getting ready for potential transplant, one of the key elements is finding a donor. So if you do go through a family and don't find a family match, and you pointed out what the stats about that is, what's the time frame in your experience to find an international matched donor?
Yes, it's a very good question, and it very much varies between patients. So there's a couple of steps along the way. So if we haven't identified a sibling or a family match, the next step, what we do is we, I guess, put a call out on the international registry, which our donor coordinator does, and that's called a book search. So we have a look in the system and put the patient or the recipients, that HLA matching that I was talking about, and we put that into the system, and then it will send us back a report that says there is potentially 3 or potentially 50 or potentially 100 matches, but we need a little bit more information. So what we do is we have a look at those patients, and we request some additional, I guess, what we call high resolution typing, or some additional matching information, I guess HLA matching information from the registry. And sometimes that involves the patients going in for the donors going in for some additional testing. And then when we get that report back, usually that will sort of narrow the search a little bit and might produce potentially 1 or potentially maybe 5 donors. And then what we need to do at that stage is actually notify the donor. And so we at the transplant centres don't have any involvement in that process to protect, I guess, the anonymity of the donor. So it's all done by our Australian bone marrow registry team, or called ABMTR team. And what they will do is they will make contact with the donor centre where the patient is closest to, and they will phone the patient and say, we've potentially, we're potentially requiring your, I guess, donation. one, would you still be willing to donate? And two, would you be able to go in for some additional testing? Sometimes we don't hear anything back from donors. Sometimes it might be a female that says, I'm actually pregnant at the moment, so I'm not a suitable candidate. Or another one is that they might have had a tattoo in the last few weeks, which will sort of preclude them for a period. So that's sort of the first step. But obviously, I guess people that put themselves on the bone marrow registry are usually very kind people and will sort of move around plans to be able to donate. But usually we will hear back most of the time. And then when we hear back from that process, we'll send them into their donor centre to do a donor assessment. And that involves, I guess, getting medical clearance to say that the donor is actually medically cleared to donate. So there's a few different steps along the way that can hold up the process. I think we would usually, once we have done a search in the registry, we would usually expect to have heard some information in a couple of weeks. And then it usually would take potentially 2 more weeks to get, I guess, for the donor to be notified and for them to agree to the donation dates, because sometimes it can be a bit challenging where we actually have found a suitable donor. They're a really good HLA match. They're from a donor centre, potentially internationally, that we use a lot and feel very comfortable with. But they might say, oh, I've actually got a holiday planned overseas in that period when you have requested that I go in for my donation. So there's many steps to that process. And I think that's that's potentially one of the lengthiest and most complex parts of the pre-transplant period is actually the donor. And sometimes we might be in a really lucky situation where we have potentially 2 or 3 donors and we have one as a backup in case our first preference donor falls through. So I think we would usually, that was a long-winded way of answering your question, but usually we would expect to have some information within about 2 weeks, but probably a month or so to really hear if this donor is going to be suitable and available when we require them. I'm not sure, David, if you have any thing to add.
No, it's a very comprehensive answer. When I'm talking to my patients about initiating unrelated donor search, and one of our hardworking donor coordinators comes across to do the sample and the paperwork to do that, I give exactly the same stepwise progress, and so it is a bit more of a multi-stage process rather than, yep, we've got a match, let's go. And that takes, in the adult lab, in the adult setting, about 6 to 8 weeks. So if we can start planning the transplant on the anticipation that we'll find a donor, we'll do so in parallel, and then the donor will get finally cleared, just as Maddie has outlined, because it's multiple steps. And the basics about donor clearance is just making sure that it's safe for the donor's health to donate, and that it's safe for them to give a product to somebody who needs one. And it's all about safety. So that's great. All righty. And we are well over time, but I think people are enjoying the Q&A. So I'll just add in one additional question, slightly tricky, but I might ask for all 3 to give an answer, because Yvonne has decades of experience, many decades of experience, as she's outlined. Maddie obviously has pediatric experience, and Alex is seeing people in that acute sort of peri-transplant place. So it's a complex question, but I'll see if I can just bring it home. So we'll ask for Maddie, Alex, and then Yvonne, and then we'll finish up. So the patient says to you, this is a question for her, the patient says to you, I've got a condition and my doctor says I should have a transplant, and I want to know what success looks like, and Alex has already outlined that a little bit in her presentation. And I want to know that someone's going to be looking after me for the long haul, and I want to know whether this is a good idea. What's my prognosis? What's going to happen to me? And overall, and the person who put in the question didn't have a specific diagnosis in mind, but it's a very complex syndrome. So I want, rather than giving us the statistics and figures as each of you answer, how do you approach that question? Please let me know if it's a good idea. And how do I be reassured that I'm going to be looked after, not just in the short term, but in the long term? And if that's not enough, how I understand that there's lots of different types of transplants. How do you know that's the best one for me? So let's start with Maddie. Your approach.
Okay. My one piece of advice I always give families when they in the early post-transplant period, it's most commonly parents or grandparents or that I'm sort of having these conversations with, is every transplant is very different. So if you're reading something online, I think that's something that causes a lot of anxiety among families, understandable, is they're potentially reading things online that might not be relevant to their particular transplant. So particularly for bone marrow failure syndromes, I always say you can't compare, I guess, to a child that is having a transplant for leukemia that has had 2 or 3 years of leukemia therapy. Like, they're always very different things. So my first piece of advice is always make sure that you're asking questions, particularly to your treating team, because I think they have, I guess, the best insight into the individual child or patient's transplant journey. So that would be my sort of biggest piece of advice. And I think transplant is our bread and butter. We have a huge, amazing team. We do transplant, like a lot of regular transplants. We have very well-established services from the pre-transplant period to the inpatient care, to the late effects, to the long-term follow-up. And so I think patients and families will be extremely well looked after. And really, we encourage you to ask all of your questions to the team. Reach out if there's something that you're feeling particularly anxious about or would like more information about. We're always very happy to direct you, I guess, to the right resources for particular information, particularly in a pediatric setting. That's important when we're trying to teach children about the bone marrow transplant process and what they might expect. So ask lots of questions and just remember that, this is our bread and butter and you're in good hands, whichever centre that you are at. I don't know if that was a good answer, but
We wanted your approach.
That's the pediatric approach. It's probably different to the adult approach.
That's perfect. Alex?
No, Maddie, you set me up for a win, so thank you. I would tell you that we're doing this. If we're getting to this stage in the conversation, you have a disease that requires transplantation and we're going for cure. And it might be that this is the only cure that we have and we're going for cure. We've got a highly sophisticated supportive care system that can support you inpatient, outpatient in many variations. And then I tell you that once a bone marrow transplant patient, always a bone marrow transplant patient, we might cut the umbilical cord for you to go back home, but you can always phone home and we will look after you the whole time.
Yvonne.
So what I say to people when they come to long-term follow-up is congratulations, you're now at least 2 years post-transplant. And the focus has shifted from us leading your care to you leading your care. And what do you need? What do you need from us in order to support you to be able to self-monitor, self-present, and to be an active participant in reducing the risk of late effects after transplant. We're very clear about what we need to do for people, but we're really, really clear about supporting people to be able to be, as I said, active participants. And as I mentioned, what we also, because I mean, people have different goals, right? You know, at the early stage, at that middle stage, sometimes people's goals are survival. Once people get to long-term follow-up, their goals vary from year to year. And as I mentioned, we address those annually. And either acknowledge that they're awesome goals or help them to achieve them through navigating the system. So that's the message that we would be giving to you at your first and subsequent annual long-term follow-up visits.
Excellent. All right, we've well and truly gone over time. I'm going to take Q&A chair's prerogative and make a quick summation. The reason that people can be confident that they will be looked after and looked after well are reflected in our three speakers. Highly trained, empathetic, honest people with integrity who have taken to their heart the care of allogeneic transplantation patients and their families, and have chosen a portion of the transplant journey to particularly concentrate and develop their expertise. And when we are fortunate enough to have the nursing staff that we have, I can be confident that our patients will receive the best care. So with that, I'll hand you back to our chair, Amy, and thank you for everyone for your participation.
Thanks so much, David. And thank you all so much for being here and for sticking with us. It was amazing content and lots to get through, but we're so grateful to Maddie, Alex and Yvonne for, sharing such brilliant content tonight. And we hope that it's been really valuable. As I said, if you haven't had the opportunity to ask a question, then please do reach out to our team. We were always here to help you in any way you need. This was actually the fourth and final patient and family educational session for 2025. Please keep an eye out next week for the email, which will have the survey link and also the recording of the session. So we already actually have our next session planned for Monday, the 16th of February next year. So we're well and truly ahead. It will be presented by Associate Professor Piers Blombury, who's a haematologist and clinician researcher at the Peter MacCallum Cancer Centre. So he'll be joined by a genetic counsellor who will explore how advances in genomic medicine are transforming the way bone marrow failure syndromes are diagnosed and understood. So keep an eye out for some more information on that session, which will come out in early next year. But thank you so much to everybody for all your contributions throughout this year and the time you take to share the information that you're hoping to learn throughout the year. We're very grateful and glad that we can be there for you and look forward to continuing on these programs in 2026. Have a lovely night and thank you all so very much. Good night.